Thank you again, and really happy to have this opportunity. Penn State Neurosurgery and Swedish have had an ongoing relationship with our residents doing fellowship training there, having visitors come here. So really appreciate this opportunity. What I'm going to talk to you about today is the science of practice in clinical research and quality improvement. And I hope that that term becomes clearer as the lecture goes on. Okay. This shows I'm adequately bought and paid for, but there's no conflict of interest with this topic. So the objectives today, after this presentation, the people who are in attendance should be able to discuss the problems with randomized trials in surgical disciplines, to understand the differences between accuracy and precision in clinical research, and to recognize how the science of practice approach may be able to supplement other clinical research options. So I'm going to start with a question, and that is, why can't we reach consensus? If you remember, the evidence-based medicine algorithm was an effort to reach consensus, to understand for the patients we see, what is the best treatment option available. And despite decades of the evidence-based medicine algorithm, lots of randomized trials, an enormous number of dollars spent on these trials and on guidelines, documents, our treatment decisions continue to remain contentious. And so it suggests to me that there is some defect in this process, a hole that needs to be filled. And the question is there a better way? So why can't we reach consensus? And I think that the answer to that is that meaningful data that's really going to change our practice, must be precise and accurate. And this is an important slide. I think if you understand this slide, you're going to grasp a great deal of the rest of the presentation. So when we talk about precision, what precision means is that if we repeat a measurement, how close will it be to the previous value? Very precise measurements, if we repeat that measurement 20 times, they should all cluster very tightly. Accuracy is completely different. Accuracy is how close is our measurement to the real world value. And I've tried to put a couple of examples on here. So let's look at the graph first. So, here are the values we get. We've repeated a study a number of times, and these are the values. And, it's the width of our Gaussian curve that determines the precision. But the accuracy is the difference between this value and the reference value or the real world value. So you can have a very precise study, a very precise group of measurements, that's accuracy is very poor. And so if you look over here, using this target illustration, all of these values cluster. So that's precise, but none of them are particularly close to the center of the target. That's precise, but not accurate. Now you can also have this kind of arrangement where there are a lot of study results, all of which are fairly close to the target center, but are very, very different. They're in all quadrants of the target. So that's accurate, but not precise. And that leaves us feeling very uncertain about the results. And of course, what we'd like to achieve is data that are both accurate and precise, that can really give us confidence in changing our practice. when we talk about biostatistics, very often what we are talking about is frequentist statistics. And what frequentist statistics do is determine the precision of our data. And the frequentist inference views the locuses of uncertainty as the data. So we're going to use, things like t-tests, for instance, to try to interrogate the data. How wide is this curve? How reproducible are the values that we get? But we can't say anything about the accuracy of the data with that kind of statistical analysis. So to really understand how accurate the data is, we have to fall back on things like trial design. And then if we want to determine our belief in the accuracy of the data, which is really what's important to change practice, the way to analyze that is with a Bayesian analysis. The Bayesian inference used the locus of uncertainty as the observer, not the data. What a Bayesian analysis does is ask the question, based on the data that I've seen, how sure am I that this is correct? So again, we have to combine these two if we really want to get research that changes practice. So I think we're all familiar with the present evidence-based medicine algorithm. We use clinical research that's published in peer-reviewed journals as the primary, or some would say the only, source of evidence. We then define a hierarchy of the strength of that evidence based on the methodology of data collection. And we accept randomized controlled trials as the gold standard for clinical research. And then after we have enough randomized trials, we derive standards, guidelines, and options from a rigorous analysis of the evidence using this hierarchy. And then the last wrinkle has been that we determine the healthcare quality that we deliver by how closely we adhere to these established guidelines. So that's the evidence-based medicine algorithm we've grown up with. I want to ask the question about level 1 evidence, and that is, are surgical randomized trials truly a gold standard? And I think to understand that question and to come to an answer, we have to really start at the beginning. First of all, why do we accept randomized trials as a gold standard in any field? Well, and Akshaw can tell you how many times he heard this as a resident, that all clinical studies are prone to error from the same three things. It's bias, confounding, and chance. Those are the three things that introduce error into any clinical study. Bias is a systematic error. It can be introduced either consciously or unconsciously by the investigator or by the participant, but it will lead to an incorrect estimate of the treatment effect. It's a biased effect. If you think back to that graph, the values we get aren't close to the real world values because of this systematic error. Clinical research can also be corrupted by confounders, and those are factors related to both the treatment and outcome that may suggest a false causal relationship. A good example of that is there's maximal resection of brain tumors result in a longer lifespan. And so the unsophisticated analysis is, well, look, here are the people who had a maximum resection, and here are the people who just had a biopsy, and the group with maximum resection lived twice as long. So of course it has an effect. But then we start to look at those patients and we say, well, wait a minute, the people who had the maximal resection were younger. They had a better Karnofsky score. They had tumors in a polar location rather than a deep location. there are a lot of other things that could lead to those people living longer beside just the surgical intervention. And so without accounting for those confounders, you can't conclude with certainty that the surgery was a causal event in having the patients live longer. And then finally, there's chance. You can have a sampling error that's not caused by bias. And the way to address chance is simply to increase the sample size. Random sampling errors will decrease as the sample size increases. So we accept the RCT as a gold standard because, ideally, this design minimizes errors from bias, confounding, and chance. If those are the three things that cause error, and we can get rid of them with a trial design like randomized trials, well, we should accept that as a gold standard. For instance, because these are prospective studies, it decreases information and recall bias. Because it's randomized and controlled, the purpose of randomization is to equally distribute those confounders we talked about. So that we assume that the same confounders exist in both groups. Now we don't have to worry about them. That's how we can control for the confounders. And then the frequentist statistical analysis that we usually do, p-values, power calculations, we do those to reduce the type 1 and type 2 chance errors. So a really well done randomized controlled trial is a very, very powerful instrument. But what is an ideal randomized controlled trial? Well, if you really want to get all of the benefits of that trial design, you need a trial that has concurrent comparison to eliminate temporal bias. In other words, patients get randomized to treatment A or treatment B, and then they're followed from that point forward. You need unbiased or masked observation of clear and clinically meaningful endpoints so that you eliminate any observer bias or patient bias. And if you get a statistical difference, you can say there's probably a clinical significance to that as well. So concurrent comparison, a masked study or a blinded study, and then you need to randomize a representative population of adequate size so that you will distribute those confounders, have a generalizable result. Does your treatment group really resemble the population that you're trying to investigate? And so the way to think of this is if you have an adequately powered double-blind study of aspirin versus placebo, following a myocardial infarction, and we use death as the outcome of interest, a very clear and clinically meaningful outcome. That kind of study, the results of that would be very, very powerful. It would be hard to ignore the results of that type of randomized controlled trial. But how often do we do that in surgery? And the answer is almost never. So let's look at these essential components. So essential component one is concurrent comparison. And you know that in surgical randomized trials, you often hear about an intention to treat analysis and crossovers. And this is really important. So if you really want to have a randomized trial to preserve those benefits, you need to analyze patients in their assigned groups, even if they cross over to another treatment arm. But we have to ask ourselves, is this rational? Do we believe the results if surgical patients in the trial never receive surgery? And if non-surgical patients do? And this is really problematic for surgical trials because the crossover periods are asymmetrical. If someone randomizes to surgery, they're going to have an operation usually within a few days to a few weeks. Whereas if somebody randomizes to non-surgical treatment, it may be months before they cross over. And so we do have some statistical methods that can help ameliorate the problem, but they don't eliminate it. And if you have a large enough number of crossovers, you really have a hard time believing the data. So let me give you a kind of old example of this. When I was still at Dartmouth, the orthopedic group up there was developing this spine patient outcomes research trial, or SPORT. The first publication from that came out in JAMA in 2006, and it was looking at lumbar disc herniation. 256 patients had been assigned to non-operative care, but 30% of those had had surgery at 3 months, and 45% had had surgery within 2 years. And so the way this trial worked is patients would get randomized to surgery or no surgery, and then they would have their surgery if they are in the surgical group, usually days to weeks. But if they didn't have surgery, they could have physical therapy, they could have acupuncture, they could have chiropractic, they could have injections, they could have whatever other treatments people do to try and take care of patients with back and leg pain. And then if that wasn't working, they could go ahead and have an operation. And as you see here, the endpoint that was of importance in the study was at 2 years. Almost half of the patients in the non-surgery group had surgery before the endpoint was reached. So if that person was doing well at 2 years and they had an operation, let's say they'd failed everything else, or they wouldn't have had the operation, that was counted as a good result for non-surgical treatment, because that's how they had randomized. And this is a quote from the paper. And if you look at the as treated analyses, they demonstrated a strong and statistically significant advantage for surgery at all follow-up times. So the intent to treat analysis showed only a slightly better outcome score for the group assigned to surgery at each time. But because this was a RCT, it was that intent to treat analysis that was published. And based on that intention to treat analysis, what was reported, well, you can guess. And this is what came out in the New York Times shortly after the publication. The study questions the need to operate on disc injuries, which of course was not at all what the study showed. And then a quote from that article was, everyone was hoping the study would show which was better, and everyone was surprised by the tremendous number of crossovers. In the end, the study could not provide definitive results on the best course of treatment because so many patients chose not to have the treatment that they had been randomly assigned. So we spent about $30 million on that study, it was a multi-center study. And the basically concluded that, well, you can try other things for people with disc herniations, and if that doesn't work, operate on them. That was very close to what we were doing before we spent the $30 million. So the results of this study had very little effect on how we treated patients with lumbar disc herniation. So let's look at the second essential component, and that's that we need unbiased observation of clear endpoints. And to have unbiased observations, you really need to have blinding or masking. And as we all know, masking is difficult or sometimes impossible in surgical trial. Endpoints may be vague. And so if it's an unmasked trial with a vague endpoint, you're going to introduce bias either for or against surgery. And I think the take-home message, if it's an unmasked trial, it's a biased trial. And it doesn't solve the problem by saying, well, we'll have somebody evaluate the patient other than the operating surgeon. If that person who's doing the evaluation is unmasked, then we've simply substituted that person's bias for the surgeon's bias. There is no such thing as an unbiased observer who's not masked. So let me give you some examples of that. So a little more recent study, Crest. As you know, this was an open, prospective, multi-center RCT. It was comparing endarterectomy versus angioplasty and stenting for carotid stenosis. And the primary composite endpoint was stroke, death, and MI. That had been used in some other studies, so not completely unheard of, but again, makes things a little bit vague. And if you looked at the results, if you looked at the peri-procedural results or the results at 4 years, there was no statistically significant difference in the outcomes between endarterectomy and angioplasty and stenting for that composite endpoint. And so again, what was reported is that these were equivalent procedures. But if you really look at the data, angioplasty and stenting was superior to endarterectomy, statistically significantly better for myocardial infarction in all patients. Remember, that got rolled into that composite endpoint. And of course, for cranial nerve injuries, it's hard to get a cranial nerve injury endovascularly. Endarterectomy was statistically superior to angioplasty and stenting in procedural stroke in all patients, procedural stroke in symptomatic patients, procedural stroke and death in all patients, procedural stroke and death in symptomatic patients, the 4-year stroke rate in all patients, the 4-year stroke and death rate in all patients, the 4-year stroke and death rate in symptomatic patients, and maybe most importantly, in the quality of life. That, stroke, which was lower in the endarterectomy group, had a greater effect on the quality of life than MI, which had, was lower in the angioplasty and stenting group. And the two areas where there was no significant difference was in the composite endpoint, which was published, and myocardial infarction in symptomatic patients. Now, I think that last one is actually very important because my practice for a long time has been to operate almost solely on symptomatic carotid stenosis, not asymptomatic carotid stenosis. And so I think the data from Crest are a pretty strong endorsement of endarterectomy, but that's certainly not how it was reported out. Here's another one that I found really troubling, and I think a lot of people did, and that was the Aruba trial. This was an open, prospective, multi-center, randomized trial comparing medical management alone to medical management and interventional therapy for unruptured AVMs. The primary outcome was time to the composite event of death from any cause or symptomatic stroke. And symptomatic stroke was defined as symptoms associated with imaging findings. And using that definition, an interim analysis performed after 6 years with a mean of 36 months, so mean follow-up of about 3 years, so that the primary outcome was reached in 31% of the 114 patients who had interventional therapy, and that could be endovascular, surgical, et cetera, and in only 10% of the medical management group alone. And so, they said, wow, this is such a big difference. We've really reached an endpoint here. It's futile to continue this study. And so the results of Aruba were that for unruptured brain arteriovenous malformations, you should just leave them alone. I think a couple of telling things about this. One, this 10% risk of the untreated AVMs over a mean follow-up of 3 years is what a number of other registry studies have shown, that there is somewhere around a 3%, anywhere 2 to 4% per year risk of rupture of previously unruptured AVMs. And this goes on throughout the life of the patient, perhaps actually increases as the patient gets older. And if you stop your study at 36 months, you're never going to truly appreciate the effect of that ongoing 3% per year rupture risk. The other thing that's concerning is this diagnosis of stroke. So let's take the following example. Say somebody has a right frontal AVM, it's resected completely. Immediately post-operatively, that patient has some clumsiness in the left hand. You get a post-operative CT scan, which obviously shows imaging findings. That patient is now determined to have had a stroke, and that symptoms with imaging findings, the patient's reached an endpoint. So if that patient comes back at 6 weeks, the clumsiness is resolved, there's no more AVM, I would suggest that patient is much better off than the person who didn't get operated on, never had 6 weeks of hand clumsiness, but still has an AVM with a 3% per year risk of rupture. But based on how the study was designed, that was never going to be found. Now, this was some data presented at a meeting that I've never been able to find in publication. So take it for what it's worth. The person I know best here is Stefan Meyer, who's very well-respected neurointensivist. And it was basically an increase in ruptured cerebral AVMs and mortality after the Aruba trial. And so again, you don't know if this is cause and effect or just correlation, but the data are pretty striking. If you look at the pre-Aruba trial area in dark blue and post-Aruba trial era in the light blue, how many AVMs present as ruptured? Number goes up pretty substantially after Aruba. And if you look at the mortality, that also goes up pretty substantially. And I have looked for this in the peer-reviewed literature and haven't been able to find it. If anybody knows where it is, please let me know. Some other problems with surgical randomized trials. Remember, our essential component of the ideal randomized trial is you have to randomize a representative population, and that population has to be of adequate size. So patients and surgeons within the trial, really have to be representative of the patients and the surgeons in the general population if we want the results of the trial to be accurate. Again, think back to the graph. We can get the results of the trial, but then unless they actually reflect the real world value, the accuracy of the study is called into question. We also need to remember that surgeons have an implicit contract with the patient to offer the best care available. In the lingo, that's the therapeutic imperative. And if surgeons don't believe that both treatment arms are equally efficacious, if the surgeon doesn't have equipoise, they're going to offer surgery to patients they think will most likely benefit outside of the trial. And they're going to randomize only those patients they think are least likely to benefit. Now, when biostatisticians talk about equipoise, they often talk about, the literature. What's in the literature? Do we have equipoise for these two treatments in the literature? But I would suggest that the important equipoise is not in the literature, it's in the surgeon. What does the surgeon believe in regard to the effectiveness of treatment? Again, let's go back to the sport study. So here are the different populations to consider. So for sport, the target population was all people with herniated lumbar discs. Then you go down and you narrow that group to the accessible population. And that's all of the people within a reasonable distance of the centers that were involved in the study. And then the intended population, those are actually patients who are referred to those centers with a herniated lumbar disc and offered the option of joining the randomized trial. And then finally, the actual population is those patients who were offered that opportunity and went on to have enter the study and be randomized. When this study got started, my wife and I were both practicing in New England. I was at an academic medical center. She was in private practice. And it became very clear that the referring physicians in the area, if they had a patient with a very clear-cut disc herniation that they knew would benefit from surgery, they would send it to the private practice group because they knew they'd just get operated on and do well. If they had the patient who was a little more difficult, kind of a bulging disc, a lot of back pain, as well as a lot of leg pain, not quite sure if surgery was the way to go, more of those patients got sent to the academic center and more of those got randomized. So, in that case, the actual population really wasn't completely representative of the target population, because I think a lot of the good surgical patients were weeded out before they ever got to the point of choosing randomization. And then one other point, in surgical randomized trials, surgical skill is viewed as a constant. And we know that's not true, that the skill and judgment of the surgeon is something that has a significant effect on the outcome of the patient. Going back to our ideal RCT, the aspirin versus placebo study, it really doesn't matter if it's the chief of cardiology or the intern who writes that order, aspirin versus placebo. But it would matter a lot in a surgical trial if it was the chief of neurosurgery versus the intern doing the operation. But in RCTs, surgical skill is just accepted as a constant. So here's I think a very good example of representative patients and surgeons. If you remember the Crest study, they concluded that endarterectomy, angioplasty, and stenting were equivalent. But that was in a study with, highly selected patients, highly selected operators, whether endovascular or surgical, and a very good study with Tom Brott as the senior author that came out in JAMA in 2017. Took a little different approach, and that is to say, well, let's look at carotid endarterectomy and angioplasty and stenting in the U.S. Medicare population, and we'll do this, over a period of, 15 years, and that was, approaching 1 million endarterectomy patients, 231,000 angioplasty and stenting patients. And they looked at 30-day outcomes, endarterectomy versus angioplasty and stenting. And remember, these are administrative databases, so they're not perfect. But there's some really interesting data points. And if you looked at stroke and death, endarterectomy started out at 4.4% stroke and death rate in 1999, and that dropped to 3.1% by 2014. Over that same period of time, angioplasty and stenting stroke and death rates started out at 7% and ended at 7%. So it suggests that, improvements in technology, more experience as time goes on, really didn't demonstrate a, dramatic reduction in stroke and death. But there's probably something inherent about the approach that has, a floor effect on stroke and death following the procedure. If we looked at the same thing that was done in Crest, stroke, MI, and death, endarterectomy started out at 4.7% and went down to 3.4% in 15 years. And once again, angioplasty and stenting started at 7.4% and ended at 7.4%. And then if you look at all-cause death, endarterectomy, 1.6% to 1.1, angioplasty and stenting, 4.7 to 4.8. So the real world data here suggests that it's not what was shown in the Crest study, in that we really have to ask, is that study accurate? Another problem with randomized trials is evolving technology. And this comes from an article in the British Medical Journal in 2016, looking at endovascular treatment versus medical care alone for ischemic stroke. And this is a meta-analysis. And I think people, sometimes don't remember that we had 3 randomized trials of looking at, invasive endovascular treatment for patients with large vessel occlusion versus medical management alone, and that none of them showed a benefit for intervention. And the meta-analysis did not show a benefit. So if we really believed the results of our gold standard, we would have stopped and said, okay, we've done 3 randomized trials. We can't show a benefit of this treatment. We're done. But I think people didn't believe it. Again, this goes back to how accurate was the data. And I said, no, wait a minute. If you have a large vessel occlusion, you have brain that can be salvaged, and you can remove that occlusion, there's a lot of reason to believe that that is going to have a benefit for the patients. Let's look at the trial design a bit and see, if we can improve it. And there was lots of ways to improve it. The technology got better over time. There were a number of patients who were randomized to the endovascular treatment group, who, when they had an angiogram done, didn't have a large vessel occlusion. And so, despite the fact that there were 3 gold standard studies showing no benefit, you then look at the next, let's see, 1, 2, 3, 4, 5, 7 studies. In 6 of those 7 randomized studies did show a benefit, and the composite showed a pretty substantial benefit. And personally, I think that the introduction of thrombectomy for acute stroke patients has had a pretty profound effect on our patients, and certainly something that has been a benefit to many, many patients. And it would have been a shame to have missed that opportunity because of 3, the 3 gold standard studies that weren't accurate. So is there a better way? And so what we've proposed is this science of practice algorithm. And the science of practice is the habitual and systematic collection of data, should be inseparable from practice, via audited registries. And audited is important. We have to have a certain standard for the data that we're collecting. These data are collected to allow analysis of patient characteristics, processes of care, and outcomes. This data analysis then does generate new knowledge about the effectiveness of our care, helps us to refine our operative indications. And if we have a new treatment, if we have an innovation in treatment, we can assess that by just adding that option to the registry. This shows the differences between an evidence-based medicine algorithm and a science of practice algorithm. So evidence-based medicine is really based on the population. We're going to take a population, we're going to divide that population into 2 groups. We're going to compare that the outcome with the 2 treatment options, and then whichever one is best, we're going to apply to the entire population. We know that there are probably people who respond better to one than the other, that one size doesn't fit all. The science of practice is designed as an individually based approach. Patient with these characteristics treated with this type of approach will have this likelihood of a good outcome. So it's really looking at the problem in a different way. Evidence-based medicine is the based on the randomized controlled trial, where science of practice is a registry-based approach. Evidence-based medicine is a discontinuous process. You do the study, you do the analysis, you publish, and then you do it over again. Science of practice is an iterative process. As you get more and more patients in the registry, the power of that registry increases. In the evidence-based medicine algorithm, surgical skill is uniform. Everybody's the same. But surgical skill is a variable that can be analyzed in the science of practice approach. Evidence-based medicine is both prescriptive and proscriptive. We get the results, we publish the guidelines, and it says, you should do this, you should not do that. Whereas the science of practice really encourages innovation. If you think you can do something better, if you can give patients a better outcome, put that variable into the registry and see if it does result in improved outcomes. And finally, the evidence-based medicine approach, compliance determines quality. How closely do you adhere to the published guidelines? Whereas in the science of practice, it's your outcomes that determine quality, which I think is a much more reasonable thing to do. So we've accepted the power of registries for quality improvement. I think that argument's over. But we're actually pretty early in using this observational kind of data to do real clinical research. And I think, again, we have to think about RCTs and how they differ from a well-designed prospective observational study. And there's really only one difference. I mean, they're both prospective. We want to collect the same data on everybody. We want, the data to be audited and valid. But the one design element that the RCT has that the registry doesn't is randomization. And so the patients get allocated to different treatment groups through a random process. And remember, why do we do randomization? So the only reason to randomize is to reduce the risk that the trial results are distorted by confounders, bias, confounding, and chance. And so, one way to get rid of confounders, to address confounders, is to randomize. In an observational study, we know that treatment selection is influenced by factors that may differ among groups. And so we have to account for these factors, for these confounders, if we want to determine a treatment effect. One way to do this, it's not the only way, is propensity score matching. And the propensity score is the probability of treatment assignment due to baseline covariates. So go back to the brain tumor example I used. How likely are you to recommend surgical treatment for the patient with a right frontal brain tumor who's 30 years old and has a good Karnofsky score versus the 75-year-old patient with a thalamic glioma? Patients with the same propensity score will have the same distribution of these covariates that determine treatment assignment. And propensity analysis allows a well-designed, non-randomized prospective observational database to mimic randomization. And then causal inferences can be drawn from such a well-designed prospective observational database with propensity score matching. So it addresses the confounders in a different way. The one thing it can't do is if there's some unknown confounder, it won't be able to address that. So let's look at these trial design comparisons then. Remember, bias, confounding, and chance were the issues. So do these trial designs address the sources of error? In regard to bias, are they masked? Well, neither the randomized controlled trial and surgery nor the propensity score matching is masked in almost all cases. So the answer to both of those is no. So we're never going to have the same level of confidence that we have in the aspirin study. Are the studies prospective? Yes and yes. Do they address known confounders? Yes and yes. Do they address unknown confounders? Well, the randomized trial does by randomization. If there's some factor that is affecting our treatment assignment that we just don't know about, I think that's pretty unlikely. But if there is, then our propensity score match will not be able to address that. Do we have a representative sample? And I think this is where the propensity score match registry is superior, because we're taking all patients. We simply record all of their covariates, what happens to them, what their outcomes are. Whereas in the RCT, as you know, both the surgeons and the patients tend to be very highly selected. And are they adequately powered? Well, we can determine that for both, but your N's are almost always going to be larger in the propensity score match registry. So each has its value. So to finish up here, I'm going to go through a thought experiment. Is how to treat unruptured intracranial aneurysms. And we're going to consider these two options: a randomized controlled trial and a prospective observational database with propensity score matching. So let's think about the RCT for a minute. Let's say we're going to set up the trial to say this will be for patients aged 18 to 75, unruptured aneurysms 3 to 12 millimeters in greatest dimension. And we're going to compare observation, clipping, and coiling. Well, first we ask, is there equipoise? And remember, this is equipoise among the treating surgeons. So first patient in your clinic is a 24-year-old woman, positive family history of subarachnoid hemorrhage, cigarette smoker, has tried to quit, hasn't been able to, has an 11 millimeter irregularly shaped basilar apex aneurysm. Would you randomize that patient? Well, most of my friends in the cerebrovascular community say what I would say, and that is no. First of all, I think we have good data to suggest that an aneurysm that size, that shape, that location in a cigarette smoker and in a patient with a positive family history of subarachnoid hemorrhage has a higher risk than the normal patient with an unruptured aneurysm. And at 24 years old is really at considerable risk. And an endovascular treatment of that basilar apex aneurysm would have a much lower lifetime risk for that patient than leaving it alone. And so I would, take care of this patient outside of the trial. Furthermore, even if you said, well, we have this trial, I'm going to randomize you, I think because she had a family member with a subarachnoid hemorrhage, her answer to that would be, thank you very much, but I'm going to go someplace where I can get this fixed. And so that patient would never get in the trial. Now, the next patient in your clinic is a 70-year-old woman, no family history of subarachnoid hemorrhage. She's a non-smoker. She has a 3 millimeter, nice, hemispherically shaped ophthalmic artery aneurysm. Would you randomize that patient? Well, in my practice, I would tell that patient the best thing to do is just, follow this for a period of time to make sure there's no growth, but likely not get treated. But if there were a randomized trial, I might offer that to her, and if she entered that, would get randomized. So you see what we've done. We've taken the patient most likely to benefit from surgery and taken them out of the population. And we take the patient who I think is least likely to benefit from surgery and randomized that patient. And then how long do we do the follow-up? Remember, we're doing this as a preventive operation. Do we do it at 1 year? Well, I guarantee if you're comparing interventional therapy to observation for unruptured aneurysms for 1 year, observation is going to win every time. It's not a long enough period of time for the natural history risk to catch up with the procedural risk. So how about 2 years, or 5 years, or 15 years? I think that's an open question. So now let's look at the other approach to this, and that's propensity score matching. So what questions do we need to answer? Well, the first one is, what randomized experiment do you want to model? Who are the decision makers for treatment assignment? What are the key covariates that are used to assign treatment? Can we measure those covariates? What clinically meaningful outcomes will we measure? And what sample sizes will be needed? And if we have satisfactory answers to those questions, we will be able to draw causal inferences from non-randomized data. So what experiment do we want to model? Observation versus endovascular or surgical treatment, patients with unruptured intracranial aneurysm. Decision makers for treatment assignment are the physicians, the patients, and the family members. Key covariates that we use to decide what treatment is carried out. And so, there are the patient factors like age and prior aneurysm ruptures and comorbidity, social history, family history, et cetera, aneurysm-specific factors, and then physician-specific factors, all of which can be analyzed. And we can define and quantify these key covariates well. Clinically meaningful outcomes we want to measure, mortality, functional health status, quality of life, aneurysm rupture, all of which are easily done. And then we can use traditional power calculation to know how many patients we're going to need to enroll to get reasonable answers. So no study is perfect, and prospective observational databases have their drawbacks as well. First, you need the infrastructure for data collection, analysis, and feedback. It has to be properly designed for propensity score matching, as we just went over. There needs to be a commitment to continuous data collection. All the patients need to get entered, and all the outcomes need to get entered. And auditing for data completeness and integrity is needed if we want people to believe the results. And we will not be able to address unknown confounders. How much of a problem that really is, I think it's questionable, but that is the one drawback. So summary is, the application of our present evidence-based medicine algorithm really hasn't allowed us to reach consensus on treatment in many areas. And it's often because we don't believe that the randomized controlled trial results are accurate, that they're generalizable to the population. We know that within the constraints of the trial, this is what was seen. But if we do a Bayesian analysis, if we say, what's the level of certainty that I have in the accuracy of these results, we just simply don't believe the results. And that's not because we're recalcitrant or just stubborn surgeons. It's because there are very legitimate reasons for questioning the accuracy of many such trials. And I think the science of practice using prospective observational databases that are designed to allow causal inferences to be drawn will help us improve our clinical research in the quality of neurosurgical care. It doesn't necessarily mean that they have to replace RCTs, but it's certainly another part of the armamentarium in trial design that we can use to generate valuable data. So thank you for your attention, and happy to take any questions. So should I take questions from the chat?
Akshal, do you want to start?
Sure. So Dr. Harbaugh, I know you touched on briefly, thank you very much for that great presentation, and the mantra of bias, confounding, and chance. I just feel like it was burnt in my memory as a resident, just coming forward. And then I think you gave Dr. McDougall some PTSD with the whole, aneurysm, should we not treat it or not? But anyway, I want to ask you just, and you touched on your last slide about Bayesian analysis. Could you just explain to the audience just a little bit about Bayesian analysis? I know that very few people have come across it because frequentist statistics is so prevalent in our education.
Right. So what Thomas Bayes was an English theologian, mathematician, and he asked the question of what is the relationship between an event related to the prevalence in the population versus the prevalence related to an event. In other words, if you hear someone sneeze, what's the likelihood that that person has a cold? Versus if somebody has a cold, what's the likelihood that that person's going to sneeze? And where we've used Bayesian analysis most frequently is in evaluating diagnostic tests, where you say, okay, I've got a positive test, but I can't really tell what the positive predictive value of that is without knowing what the prevalence of the disease is in the population. And just very quickly, so suppose the prevalence of the disease in the population is, 1 out of a million. And let's say you have a test that's both very specific, 99% specific and 99% accurate. And so you do the test and you get the result back and you say, oh, well, this test is positive. They must have the disease. That's not true, because even if you only have a 1% chance of getting a false positive, that's 1 out of 100. So when you only have one true positive out of a million, you're always going to have way more false positives than true positives, even with a very, very good test. So, it's letting you know your confidence in the outcome of the study. You can do exactly the same thing with this type of clinical data. You say, okay, what is my level of confidence in not treating lumbar disc herniation with an operation? And say it turns out that I'm pretty confident that operation works. So now you do a randomized trial or any other kind of study, and you see the data from that. What a Bayesian analysis does is ask, how does that new data change your level of confidence? So the Bayesian approach is to say the locus of uncertainty is in the observer. How likely am I to believe that? Whereas a frequentist statistics looks at the locus of uncertainty as the data, interrogates the data. I'll come back and do a lecture on Bayesian analysis if anybody wants it. But that's the 3-minute overview.
No, we would love to have you back for that. Cameron, Dr. McDougall, do you have any other comments?
I really enjoyed the talk, and it sort of I feel a certain sense of despair over what I would call the tyranny of the randomized clinical trial payer complex, because a lot of our treatments become paid or not paid based on some of these gold standard trials that are, as you pointed out, highly flawed. I think we saw a little bit of that in that slide you showed about the stenting versus endarterectomy, and that's an enormously illustrative example of how data is spun and misinterpreted. And what happened there was that the stenting was then relegated to a certain population of patients who were the higher risk patients, and so they, that's part of why they never progressed. I think in terms of their bad outcomes over time, is because that whole technology got stuck in the regulatory world, and it just can't get out of there.
Agreed. We've put too much reliance on, an ideal randomized trial is very powerful, but it's powerful because it addresses, bias, confounding, and chance. And if, the operators and evaluators and the patients are not blinded, it doesn't address bias. And, if you really take a highly selected group of patients and operators instead of what's in the general population, it really doesn't address the confounders either, because, you say, well, if people have this, this, and this, we won't do it. And so the surgical randomized trial is far from ideal.
And the lack of generalizability you've touched on really nicely as well is people not sort of appreciating just how focused trials are and generalizing the results. The big one being, in our world, the aneurysms, taking data from ruptured aneurysm trials and extrapolating to unruptured aneurysms. I mean, it's just completely inappropriate, and yet, widely done, really because the model you're proposing hasn't been available enough.
I agree. I can remember a patient. I was actually the father of one of our ENT surgeons. Had repetitive TIAs, had been worked up, found to have about a 40% carotid stenosis with a deep ulcer. Was put on antiplatelet agents, continued to have TIAs. Had seen his neurologist and was told that, based on the randomized trial, there's no reason to consider surgery because, there was no benefit of surgery for stenosis less than, 50%. Went on to have a minor stroke, at which point his son said, look, I want you to see this guy. And I said, well, yeah, but he's tried all this other stuff. The degree of stenosis is a pretty blunt instrument, to predict biological behavior, and went on to have surgery, did well. And at the time of surgery, of course, had this deep ulcerated plaque with, a very good source of embolus. So, we can't just try and cram every patient we see into the results of the randomized trial, because there are a whole bunch of them that don't fit.
The databases we have, I think of the vascular databases, for example, tend to, well, almost universally include only the patients we treat, the patients we operate on. How do we address that selection bias in patients that are selected for treatment versus patients that aren't when we're trying to apply this methodology?
Yeah, so I think that's a really good question, Ken. And if you really want to design a prospective observational database that you can use propensity score matching and draw causal inferences, you have to include all the patients that were referred to. And you say, okay, I made a decision to, do endovascular treatment for this young woman with the basilar apex aneurysm. I decided not to do anything for the elderly patient with the ophthalmic aneurysm, and they all need to be followed. And so, you can, and I think what you would find if you did that is there would be a group of patients for which there is already consensus that everybody involved in the trial is going to treat that basilar aneurysm patient endovascularly. And I think, that answer, that question has been answered. And even if we did a randomized trial, you're never going to get anybody in that group in the trial because they're all going to get treated. There's probably going to be a group where almost nobody gets treated. A lot of comorbidities, elderly patients, small aneurysm. But then there'll be a big group in the middle where there are differences of opinion. And you can look at the propensity score match and really see which does better over time. So I think that's, a much better sort of iterative approach to, getting more and more data to refine our operative indications.
I'm hogging the questions. I do want to ask one more before I turn it back. We are capturing so much more data now with our electronic medical records. There's just a vast sea of data out there that is sort of underutilized. And I see this way of studying patients being a lot like the large language models that are being used for the chat GPTs and the artificial intelligence things, and that's obviously coming to medicine. Can you speculate a little bit about how we're going to use that and what the implications are?
Yeah, I mean, I think, this is the promise of the electronic health record that's never been met. The idea was, well, we'll be able to collect the same kind of data across a wide range of practices. We'll have all of the different patient characteristics. We'll be able to see the follow-up. All we have to do is get people to agree to the features they want to include, or we could let artificial intelligence decide in an iterative fashion what are the important features to include, either one. The problem we've had is none of our electronic health records talk to another electronic health record. Sometimes even within the same system. I know we have that here. We have 8 hospitals now, and we don't have uniformity of records. We can't just log on and see what a patient had done at another Penn State Health hospital, much less trying to go across systems. And even if everybody is on Epic, for instance, every hospital system seems to have their own little twists and tweaks and versions of Epic. So, we just don't have a good mechanism yet of sharing that data over a wide range of practices. And that, I think, would be the biggest change. If we had that, we could get so much data so fast. But right now, it's still something we're hoping for.
You think the data going into the medical records is of sufficient quality to do that if we do have a common instance of Epic across a large system?
Yeah, again, you'd have to design a trial to do this right. You need to say, these are the factors we need to define. Here's how we're going to define them, and then do that for everyone. But once that's done, I mean, you need to have it audited. You have to make sure people are really doing what they say they were going to do. But yeah, I mean, I don't think that would be an insurmountable problem.
Thank you. Actually, I'll turn it back to you. I don't know if there's more in the chat that you want to.
I don't know to do to that chat, but there may be some questions you might be able to see. I can't see it from the podium here.
There's one here. What measures did you suggest to validate data presented in the POD analysis? The physician's report and opinion can be very flawed.
Yeah, so that's why I think, remember one of the key words in this was audited registries. Yeah. So, and the data suggests that if you audit somewhere above about 7% of data that's submitted, you're likely to get pretty accurate data. It's like, the IRS, they don't audit everybody, but they say we audit enough people that we make people worry about doing something dishonest. And we did that in the ABNS, where we were auditing the case logs that were submitted, and our consultant said, if you audit 10%, you're going to get accurate records, because there's a high enough risk of somebody who's submitting false data that they'll be found out. And then, if you do that, I think you can have pretty good confidence in the data that are being submitted. And remember, the data will be audited both for completeness and for accuracy. If the in the unruptured aneurysm trial, if the surgeon's note says this is a 6 millimeter aneurysm, you don't just accept that. You actually look at the study and on saying.
I think you divide by 2, isn't that the rule of thumb?
Yeah, that's right. This wasn't quite 6, it was 2, yes.
All right, any other questions, Akshay?
I think that's it. I think that's the number of questions. I thank you, Dr. Harbaugh, for your time today. I really appreciate it. And we'll definitely have you back for a talk on Bayesian statistics and analysis. That seems to be very fascinating.
People are already headed to the